All right. All right. Good afternoon to our speakers and participants all over the world. And I welcome you to another edition of Get Webinar series in this month of May. My name is Babatunde Taiwo, a Senior Project Officer with Global Emerging Pathogen Treatment Consortium, GET. And I'm going to be your moderator for today's webinar. The topic for today's webinar is going to be building innovative healthcare financing in resilient health systems in Africa. Firstly, I want to introduce GET to some of us participants that are just joining us for the first time. Global Emerging Pathogen Treatment Consortium, GET, was established in 2014 as a direct response to the 2014 and 15 Ebola virus disease outbreaks in West Africa. It was realized that most of the assistance that were coming for Ebola crisis in 2014 was mostly from outside of Africa. So in that vein, there is need to create an African-led multidisciplinary forum of experts capable to working together to strengthen African preparedness and resilience in tackling such infectious disease outbreaks, public emergency, pandemics, and biosecurity threats, which resulted in the formation of GET by a team of African experts. GET now operates firmly in African biosecurity space and function as a think tank. It provides high-level advocacy, research, operational, and necessary expertise to support countries and communities to achieving improved resources to combat outbreaks and other biosecurity threats that can threaten stability, peace, and security that may undermine economic growth and well-being. GET, we have collaborations and partnership with many organizations within and outside Africa. Most of our activities include, but these are not limited to capacity building, research, logistics, publication outreach, community engagement, and policy advocacy across the world. Like I said earlier, the topic for today's webinar is going to be building innovative healthcare financing for resilient health systems in Africa. Innovative healthcare financing for resilient health systems in Africa is a concept which aims to equip countries and governments worldwide to prepare for and mitigate future pandemics. So healthcare financing is very basic for development of resilient health systems that can withstand various shocks and health emergencies, including pandemics. However, these healthcare financing systems do face many challenges, not just in Africa, all over the world, which includes healthcare costs, inadequate funding, inadequate patient financial protection. The recent past COVID-19 pandemic has demonstrated and highlighted that importance of building a resilient health systems that can cater efficiently and equitably to the population under normal circumstances and respond equally well to emergency to minimize negative effect of it, and to recover quickly as soon as possible and adapt by learning lessons from the experience in becoming better performing and more prepared. On that note, it is important to build an innovative approach on how to finance healthcare system. In this regard, GET is organizing this webinar to explore innovative healthcare financing mechanisms that can help build resilient health systems. So, Phil, before we proceed to today's webinar, I would like to roll out the few guides that will be moderate that I will adopt to moderate on today's webinar. We're going to have two speakers, Dr. Olamide Okulaja and Dr. Rispah Walumbe. Each will be allocated 25 to 30 minutes of presentation. Participants can post their questions using the Q&A boxes. Comments can be posted using the chat boxes just underneath. Speakers can attend to questions related to them at the Q&A boxes, but as well, we shall harvest all the questions and allocate them appropriate to the speaker. First speaker of the day, which is Dr. Olamide Okulaja. Dr. Olamide Okulaja will be talking to us on understanding the landscape of healthcare financing in Africa and opportunities and challenges. Dr. Olamide Okulaja has a progressive career path in healthcare sector with multiple areas of focus on healthcare financing, hospital management information system, healthcare quality, human resource management, and business development. Dr. Okulaja has an MBA in International Healthcare Management from the University of Aberdeen, Scotland, and MBBS from the College of Medicine, University of Lagos. Previously, Dr. Okulaja was the Director of Advocacy and Program Development at the Farm Access Foundation in Nigeria. In his SY role, he led the World Bank Group engagement in Ogun State and Lagos State, and as part of the team working on the Kwara Commission-based insurance scheme, Nigeria, on policy and regulatory issues. He was also the part of a World Bank team supporting the strategy of Nigeria in attaining universal healthcare coverage. He was the interim partnership lead of the Nigerian consortium of the African Health Market for Equity, which is a $60 million Pan-African project funded by the Bill and Melinda Gates Foundation and the Development for International Development UK to address impediments to private sector participation in delivering quality healthcare to the undeserved. He also sat at the chair of the AHME World Economic Forum Ogun State Project Management Unit on the 14 initiatives to leapfrog activities within Araya scheme in Ogun State. Dr. Okulaja previously served as a member of several technical working groups, such as the Lagos State Core Team on the implementation of the Lagos State Health Insurance Scheme, the Lagos State Technical Working Group on Private-Public Partnership, and Lagos State Technical Working Group on the IT implementation for health. He currently serves as the Technical Assistant to the Honorable Commissioner for Health and Health Economist at the Lagos State Ministry of Health. He is also a member of Project Management Committee on Medical Diagnostics and Services Provision Scheme, a program focused on facilitating private investment in the delivery of public health services. He also leads the development of technical framework to promote access to capital by private health SMEs in Lagos State and Delta State, in addition to being a member of the core team developing on e-health strategy and policy for Lagos State. Dr. Olamide, you have the floor. You have 20 to 30 minutes for your presentation.
Okay, thank you very much, Tunde. Good morning, everyone. My name is Dr. Olamide Okulaja, and it is indeed a pleasure and a humbling experience to be able to discuss with you today on the health financing landscape in Africa. I'll quickly run through my slides and then try to ensure that I stay within the allocated time. So one of the first things that I really want to talk about is a lot of times when people talk about health financing, the assumption is that it's a situation where you just look for money to finance healthcare, or you look for money to ensure that people are able to access care. However, health financing is more than just revenue generation. It is all-encompassing. And it is a core function of health systems that can enable progress towards universal health coverage by improving effective service coverage and financial protection. So what it does is that it really lies on three tenets, and it is a means by which funds are generated, funds are allocated, and funds are utilized for healthcare. It encompasses both the demand and supply side functions of a healthcare service delivery system. And the WHO has sort of divided it into three core functions, which, of course, I just mentioned: revenue generation, pooling of funds, and the purchasing of services. And so basically, when you look at most African countries, they have a predominantly out-of-pocket financing mechanism, which basically means that when people want to access healthcare, they usually have to pay for out-of-pocket. Now, ironically, out-of-pocket payments are the most efficient form of payments. However, in a country that struggles to get revenue, or people are predominantly poor, this would most of the time lead them to financial hardship whenever they are trying to access healthcare. So it is important to put in some level of health financing mechanism that would assist and mitigate the hardship that people face when they try to access healthcare. So when you talk about revenue raising, it includes several forms of health financing mechanisms, which can include government budgets, where a government collects taxes and allocates some of those taxes towards financing healthcare systems. It also includes compulsory or voluntary prepaid insurance schemes, such as state health insurance, private health insurance schemes. And of course, it includes direct out-of-pocket payments and external aid. We'll talk about all of this in detail as the presentation goes on. And then the next tenet of health financing is the pooling of funds, where we accumulate all these different sources of financing mechanisms on behalf of some or all of the population into a pool, because the bigger the pool, the stronger the pool is in being able to provide the revenue required to finance their health delivery needs, especially in some form of central approach system. And of course, when all these funds are then pooled, it then involves the allocation of resources to different health service providers to purchase services. And a lot of times when we talk about health service providers, people think about just hospitals, but there are different types of health service providers, which can include or encompass research. It can encompass detection, genomic studies, availability of healthcare services, both at the primary, secondary, and tertiary levels, and the different types of healthcare services that are available across the entire spectrum. So in understanding health financing, one of the biggest things to understand is that the health financing, there is a direct linkage, and it is a virtuous cycle where you have both the supply side financing and the demand side financing interlocking based on the relationship between the demand and the supply of healthcare. Now, when we talk about demand and supply, the common denominator in demand and supply is quantity. So demand is defined as the desired quantity, and supply is defined as the available quantity. And so the demand, the demand is facilitated by supply side financing, or it facilitates supply side financing, and demand side financing facilitates supply. Basically, what that means is that if people are able to pay for healthcare either directly or indirectly, it will facilitate the supply of funding into the supply side, which are the facilities, and that in itself will then result in supply side financing cater to the desired quantity of healthcare services that are required. So health financing is the critical bridge between both the demand and supply sides of the healthcare system. Now, you look at the landscape of health financing in Africa, and sometimes when you look at this, it becomes quite dire. When you look at things like the Human Capital Development Index, you realize that most African countries are the least in investing in the factors that drive human capital development, such as healthcare, education, security. And in 22 or 45 countries, the level of funding for health is below the minimum level of the $60 per capita recommended for 2015 by the High-Level Task Force on Innovative International Financing for Health Systems. Basically, what this is saying is that African countries are not allocating enough resources to health, and so our healthcare systems are still very much in its rudimentary phase and are unable to be able to cater to the rising demand of healthcare needs by its population. Many African countries have shown to have limited capacity in raising public revenue, mainly because the informal nature of their economies makes tax collection difficult, including payroll tax collection or social health insurance. And so a lot of times, for you to be able to raise revenue in the traditional way, where governments raise revenue, you must be able to effectively tax or collect these funds that are required with as little administrative effort as possible. Now, for countries where these have been successful, it has been shown to have a high formal to informal ratio, because it's usually easier to deduct at the source of paying salaries or receiving income. But when you have a largely informal population, where the umbrella of both government and employers do not cover those that are generating revenue, where we cannot estimate the amount of funding or revenue an individual is making, then it becomes a lot more difficult for us to be able to raise revenue as a government to deliver the healthcare services that are required. And so countries with a low level of public investment in health have high out-of-pocket payments, which basically means that if a country is unable to generate enough revenue to be able to provide health services, then people will then have to pay for healthcare services out of their pockets. And remember, we just talked about it, that in a population that is actually really poor, if they're paying out of pocket, then it exposes them to financial hardship, and it basically reduces their quality of life, and sometimes they may not even be able to pay for these healthcare services, resulting in high mortality and morbidity rates. And so out-of-pocket payments are well documented as a hindrance to accessing healthcare services, especially in countries that are underdeveloped or developing and are poor in nature. And so when you look at the challenges with Africa's health financing mechanisms, the first is that there are narrow sources of funding, as most states and countries pursue only health insurance. And in pursuing health insurance, again, the health insurance that is pursued around Africa, especially in countries like Nigeria, a lot of times are voluntary, because even if you want to make it mandatory, the ability to enforce the mandatory nature of health insurance is also very difficult, again, because of the demographic nature of the population of the country. The second is that you have fragmented pools of funding, which means that all the fundings that come into the healthcare system are in silos, and the more fragmented the pools are, the weaker the pool because of the purchasing power. If we're able to coalesce all of these different fragments, then it will strengthen the pool, and the ability for that pool to purchase healthcare services will become much stronger. The third is that largely the populations in Africa are poor, and for instance, in Nigeria, 42% of the population are multidimensionally poor. And of course, we've mentioned this, that the large informal sector makes it tough for government to collect the required funding. Now, if you look at the implications of poor health financing mechanisms for Africa, I'm not really going to go deep into this, but if you look at this, you realize that the implication includes just using the maternal mortality rate and the under 5 mortality rates. They are quite high and extremely very high across Africa. And this is basically because of the poor financing mechanisms that occur in Africa. Now, when you look at the fiscal environment of a country, it defines its approach to social services. So you look at the kind of governments that we generally have across Africa, and we tend to want to move towards a socialist type of government, where government takes the responsibility of providing services to its people. A lot of times when we have political leaders that are trying to campaign, or during their campaign sessions, one of the things that they promise include free healthcare, they include free education, and several other things, which basically means that if you are to access all these services, the government will be paying on your behalf, or will be funding all these systems, because nothing is actually really free. If something is free, somebody else is paying for it. You are not just the one paying for it. However, in a country or state where the government is generating enough revenue, it can deliver healthcare as a social service. And so when you look at the very definition of socialism, where government is in control of the different factors of production and able to generate revenue. So for example, they own different businesses, they are able to tax people effectively, then they can use the revenues that they generate from all of these things to be able to offer, in quote, free services and fund the different aspects of the healthcare system, right? And that can be a social approach. However, in a country or state where the government is not generating enough revenue, it must deliver healthcare as a business service with a form of social component, which basically means that if it's unable to raise revenue through the traditional means, it must look at raising revenue through other forms that will be able to finance the healthcare system. I mean, I went to, there was a forum I attended, and one of the very poignant statements that somebody made there is that healthcare systems must be financed by the public, whether it is directly or indirectly. And so whether it is directly through out-of-pocket payments, through interactions, through other sources of funding mechanisms, or indirectly through taxation and other forms of mechanisms that government might have put in place, health must be financed through the public. And Nigeria, majority of Africa, is unable to generate funds that will close the gaps in our health systems. And so there's a need to find other innovative funding mechanisms that will provide fiscal support to different, to the government. Now, when you look at how to actually finance healthcare systems, we generally go to what we call the DRM of healthcare financing, which is the domestic resource mobilization for healthcare. And a developing country's journey to sustainability, prosperity, and security depends on its government ability to mobilize its domestic resources to fund its operations. More than development assistance or even private sector investments, DRM accounts for the largest portion of total resources available to developing countries. And it refers to the generation of savings from domestic resources and their allocation to socially productive investments. Now, basically, what this is just really talking about is looking at the different mechanisms that are available that governments can rely on to be able to raise financing for healthcare. And it is important that for economic growth and for eradicating poverty, that we look and explore ways of financing domestic investments and social programs. Now, you look at the different types of DRM mechanisms that have been identified. The first is taxation. And basically, for you to be able to finance healthcare systems through taxation, there must be an effective tax base, because it is part of this tax base that the money will come from that will be able to finance the healthcare system. So you look at an environment like the UK, where the NHS is essentially financed through the taxation system of government, and people are able to access healthcare free at the point of service delivery. They are not exactly accessing these services free. They're actually paying for it through their different taxes, which the government then allocates to the different sectors of its budget to be able to finance different things, including health. You can also have situations like the sin taxes, where in quotes, there is a levy for luxury, such as consuming sugar goods or smoking cigarettes or beers, and based on the morbidity or mortality effect of some of these goods, a tax is levied on them, and it is redirected to build a healthcare system to be able to support them if and when they fall ill. You also have corporate taxes and lottery taxes that can be used to be able to finance healthcare systems. And these are some of the innovative ways that countries across the world have been able to fund their healthcare system. If you look at a country like Ghana, at some point, which really focused on, directing part of their VAT value-added tax towards financing their healthcare system, and it was successful for a while. But the downside of that is that it is subject to economic fluctuations, and so, again, it brings up the need to be able to find a sustainable and steady financing mechanism for healthcare systems. Now, again, health spending efficiency, which basically means that it must be ensured that we are able to pool resources together and get the benefits of the synergistic effect of pooling those funds together and ensuring that the funds that are pooled are spent in a more in a most efficient way. Of course, social health insurance is another way of domestic resource mobilization for healthcare, but for social health insurance to be effective, there must be three main tenets that support this. The first is that there must be a high employer-employee level in the country, because if that happens, then you're able to contribute in a progressive manner towards the health insurance scheme. Two, there must be some level of subsidization for those that cannot pay. And so government has to be able to put money into the system to fund that. But of course, if the tax base is not strong, then it also hinders the ability of government to put in funding. And of course, there must be facilities which are able to deliver services when people go there, and so encourage them. And donor funding is a form of health financing mechanism that has been highly relied on in African countries to be able to fund our healthcare system. But again, this is not sustainable. This does not, it promotes a dispersed health planning system, because donors will fund only things that are important to them. And so you may have things that are not funded because they are not either sensational or they do not, really impact, the objectives of a particular donor at any point in time. And so it does not, in the whole, strengthen the entire healthcare system. So whilst it is good at the short term, it actually can be detrimental in the long term, especially if the donor decides to remove his funding for whatever reason that he may come up with. And of course, you have the private sector investment, which is also some form of domestic resource mobilization, where you have a promotion of PPPs, public-private partnerships, and private sector investments in itself. Now, a country with a low tax base, government needs to focus on financialization as opposed to industrialization as a means to generating additional revenue. Now, even in countries that are developed and they have huge tax bases, one of the things they've quickly realized is that with rising populations and rising needs, right, that their tax base collection is not enough to be able to cater for the needs of those countries. And so they've gone into something that is referred to as financialization. And if you look at the difference between industrialization and financialization here, you see industrialization as a process by which an economy moves from primary agrarian production to mass-produced and technological advanced goods and services, and financialization as an economic process by which value is created by partnering, matching with the private sector technically and financially through instruments like joint venture. And so basically what we're trying to say here is that beyond just looking at tax bases, government must begin to look at actually doing business, especially in partnership with the private sector, to be able to generate revenue to add as adjuncts to the tax bases that they've been able to collect. And this is most important for countries that have a low tax base, are unable to collect enough taxes to fund their healthcare system. And so it's important that they look at very innovative and strategic ways of being able to generate revenue that will assist them in fulfilling their mandates. And so no nation can base the financing of its growth and development solely on the goodwill of other nations. Begging is not a valid or sustainable resource mobilization strategy. And, the fiscal capacity is not only a byproduct of development, it is also a key enabler that needs to be actively developed. So we need to actively really focus on building our fiscal capacity so we are able to fund, the different systems in a healthcare system. And domestic resource is a reliable and sustainable source of development finance, and it is increasingly responsible for a large percentage of development financing. So it's important, so for example, with you look at biosecurity, you look at the recent COVID pandemic. The reason why there is really a dearth of commitment and revenue allocation to building the systems that will be able to ensure that the system is resilient against impacts like this. Without an active pandemic going on, biosecurity is not sensational for people to put in funding. So you cannot expect it to be funded through out-of-pocket payments as other parts of the healthcare system would be. It has to be funded through intentional and concerted efforts by government, by raising financing from different mechanisms and directing it towards things like biosecurity that can and will be necessary to create systems in a pandemic to be able to protect the lives and livelihood of its people. Again, when we look at sustainable inclusion of the private sector, a lot of times, one of the things that private sector asks for is, incentivization, looking at the adoption of a silo approach to subsidize the business of the private sector at the expense of revenues of government, i.e. tax breaks and subsidies. However, what we need to actually be looking at is an inclusion mechanism where the perception of the private sector as partners and leveraging their capacity and funding, i.e. public sector initiated and private sector driven development. So we must facilitate inclusion rather than mere incentivization of the private sector through the right policies. So it's important that policies are put into place to ensure that government is able to effectively partner with the private sector to generate the resources and also leverage on their innovation and their strategies and the things they have been able to do for so long to be able to provide qualitative and quantitative healthcare services. And so what must we do as governments to attract the private sector investment? One, we must first of all be able to have our own political will and clear policies. So current policies are a lot of times conflicting with dwindling government commitment across Africa. But if we're able to do this, one of the things that we'll be able to stimulate immediately is a willing private sector which will ensure that we are able to build trust between government and private sector. And of course, we'll be able to stimulate innovative hybrid financing, which essentially implies an increase in government funding, funding that comes in through public-private partnerships, and of course, developmental and blended financing that is available across the world to different countries that are able to access it to finance their healthcare systems. So what are the potential sources of funding for healthcare in Africa? We have the traditional methods where we are able to increase government budgets for healthcare and donor intervention and funding. However, we also have the opportunity of harnessing private sector investments through public-private partnerships and specialized economic zones that sort of give incentives and stimulants to the private sector to be able to partner with government. So in funding plans to build a resilient healthcare system, governments can explore the following methods as discussed. So in conclusion, the benefits of a robust healthcare financing system would include 1, more access to healthcare, which essentially enhances access to healthcare for all. 2, better health outcomes, which essentially will result in improvement in the quality of healthcare delivery and outcomes. 3, a robust economy, because what this will do is that it will create jobs, business opportunities, and 4, value for money, greater value for money for those who use the healthcare system. And of course, better use of resources, which frees up scarce resources for other sectors due to partnerships with the private sector and leveraging on their financing, innovation, and strategy. So robust health financing regimes, when achieved, will have far-reaching social as well as economic benefits. Thank you very much for this opportunity, and I'll be available for questions.
Thank you, Dr. Olamide Okulaja, for that brilliant presentation and very detailed. Kindly stand by for questions from our participants. So actually, during your course of your presentation, you made mention, you are able to fully highlight the healthcare financing approach in Africa, and which makes it a universal healthcare coverage a bit challenge to Africa to attain. And you went further to explain key areas where health financing approach is attained across the globe, which include 3 areas, include revenue raising, pooling of funds, and purchasing of services. But you are able to explain the strategies to address these challenges African countries face, such as these domestic resource mobilization, which hopes to offer a leeway to the healthcare challenge we are facing in Africa to generate resources to tackle healthcare problems, for knowing that Africa is a very poor country. So we hope our policymakers and stakeholders in public can make use of this brilliant information presentation.
No, Dr. Sunday, can you unmute yourself? We can hear you.
Oh,
yes.
Sorry. Oh, okay. Yeah, so like I said, Dr. Okulaja, kindly be on standby. Yeah, you can equally go to our Q&A section to attend to any question that is addressed to you. At the end of the presentation also, we can harvest an unattended question and allocate it to a respective speaker. So without wasting much of our time, I'll go to the next speaker. Our next speaker is going to be Dr. Rispah Walumbe. Dr. Rispah Walumbe is a global health public specialist with 7 years of experience in advocacy and healthcare policy at a national, regional, and global level. Our focus on training and healthcare policy and financing, and currently practice as a health policy advisor at AmRef Health Africa. Our work in advocacy and technical support includes the advancement of the Universal Health Coverage Agenda. Our advocacy experience, which began as a medical student, stretches from the local to the global stage on matters ranging from health to social protection and the youth agenda. As a student, she has lobbied for the rights of youth at the Open Working Groups for the Sustainable Development Goal in New York, where she delivered at the intervention from youth all over the world. She additionally has a background in medicine with training and practice in Kenya, predominantly working in rural and low-income urban areas. She has supported, trained, and mentored over 200 healthcare workers across Kenya in emergency obstetrics and neonatal care services. She has equally trained over 100 public health practitioners in healthcare policy. Our recent portfolio includes leading the Secretariat for National Hospital Insurance Fund Health Financing Reforms Panel in Kenya for universal health coverage through the Ministry of Health, and lending our technical expertise to the organization and coordination of the Secretariat at High Commission on the State of Universal Health Coverage in Africa. Dr. Walumbe will be talking to us will be making a presentation on innovative approach to enhance healthcare financing in Africa.
Thank you so much, Dr. Taiwo. I hope you can hear me clearly.
Yes, we can.
Excellent. So I'll begin, and I think for one, that bio does make me seem much younger than I am, but I'm actually quite an old soul. And I think majority of the work that I have done has been focusing on the regional work around health financing, but also healthcare policy. Right now I work for AmRef Health Africa as a senior health policy advisor. But part of that work is around primary healthcare and health financing. And we've been doing a lot of work around resilient health systems. For those of you who might not know AmRef is a regional institution, an international institution that is headquartered and founded in Kenya, but is of course extending to 35 countries across Africa. And also we work in our European and North American offices, which are predominantly fundraising offices, but all our programmatic work around health systems is on the continent. So we draw a lot on the expertise that is homegrown in the continent already. And I'll take you through what some of the innovative approaches are when it comes to looking at health financing. And I'm actually very glad that Dr. Okulaja was able to really frame what health financing really is in terms of what that means for the context of Africa. And I'll go through a little bit of why innovative financing is something that's really quite a hot topic, but I think I'll focus more on the grounding principles that we must consider with whatever innovative financing approach we decide to choose. I'll touch a little bit on what the health financing, innovative financing approaches are, and of course, come back to kind of what are those key questions that we still need to answer, even as we move forward towards innovative financing. So first and foremost, I think one of the key things that I wanted to outline is when we talk about resilient health systems, it's important for all of us to understand what that means. And I think for me, when I look at when I look at resilient health systems, I really look at systems that, one, that are reflective of what the people actually want, what the people actually need. But in addition to that, that these systems respond in a way that they are prepared for any shocks that may come to the system. But they also minimize, the negative consequences that may come as a result of those disruptions or those shocks or those challenges. So I think that's the underlying, that's what we're all heading towards. And I think the COVID-19 pandemic really framed why that's an important way to look at our health systems, why it's important to understand that resilience is actually quite a critical piece when it comes to the design of how we think through our health systems. So when it comes to the rationale for innovative financing and why it's so important, I think Dr. Okulaja really talked about what the health financing landscape really is on the continent. And I think there was a lot of questions around the fiscal space, the fact that a lot of countries have a very limited fiscal space when it comes to healthcare financing, and being able to, at the core, really look at how to expand the resources that are available for the health sector, so that we're able to deliver on those services and deliver on that promise of a resilient health system. So given these, he talked about the demand side challenges and the supply side challenges, but I want to add a little bit to that in terms of what the contextual challenges may be. Some of the contextual challenges, when you look at the African context and you look at the African continent, is that we have a number of historical legacies that shaped how we design and how we structure, and even the perception of how our health systems should be. We have a lot of examples in terms of healthcare policy, how external influences have kind of shaped how we decide, how we fund our programs and projects, how we fund our healthcare system, and how we also fund social innovations in general, or social interventions in general. And I think it's important to have those historical legacies at the back of our mind in terms of how we also reflect on the selection of our innovative financing models, whatever they may be. And I think as a result of those historical legacies, health has always been viewed as as an expense rather than an investment. And because it's always been viewed as an expense, especially in the context of how we engage with ministries of health versus ministries of finance, it's always a very tall order, because as a result of us improving our ability to take care of certain diseases, our ability to deliver on services, the cost of those services are not going to reduce. They're actually going to be increasing because of the improvement in technologies, the improvement in our service delivery models, and especially kind of like the technologies that we use, so that we're able to deliver on services equitably and of sufficient quality. So I think, having said that, there's always, as I said, there's always this tension between ministries of finance and ministries of health. And I've had the privilege of actually sitting down with both of these teams and being able to sit down and figure out what the key bottlenecks are. And I think one of the things that we really need to understand is that when you have the conversation about raising revenue, which is one of the functions of the health financing system, a number of countries often default to health insurance as the answer. And I think one of the questions that, I saw one of the participants point out, and also Dr. Okulaja point out, is the fact that if you focus so much on health insurance, it's really only successful at its best when you have a very heavy majority of your population is formally employed, and you're able to draw on them to be able to contribute into that mechanism. But I think one of the things or the tenets that we should focus on is how do we make sure that we nestle our health financing system in the larger financial system for our country, so that health financing, so that health as a sector can actually be seen as a core indicator of success of a country across different sectors, be it agriculture, be it in industrialization, or any other. And I think those are some of the reflections that I often have when I'm looking at the context and I'm looking at what exactly we should be considering for health financing. So in terms of the core principles that I think we should adopt when we are discussing innovative financing mechanisms, there are certain things that the innovative financing mechanism should have in mind or should adopt as part of its operational approach. One of the key things is that the sources of funding should be, one, stable or consistent. You should be able to make decisions based off of a consistent financial flow. And often when you have conversation with healthcare providers, whether it's public or private sector, a key thing that they're unable to do is effectively plan for service delivery when the flow of funds are not consistent or they're not stable. So whichever innovative financing mechanism, it should either enhance that consistency or stability so that plans are able to be made in an effective manner to be able to deliver on those services. Another thing is that these innovative financing mechanisms should be sustainable in terms of they should enhance sustainability of the financing system. It's very important for them to do this because one of the key things that you don't want to do is to destabilize the already existing financing system based off of the domestic resource mobilization process that we follow. And Dr. Okulaja really outlined why it's how the domestic resource mobilization process follows. So sustainability in this innovative financing mechanism models is going to be really critical because this allows not only the planning, but it also makes sure that there's a progressive nature to how these innovative financing mechanisms contribute to the overall financing system. The third, and I think Dr. Okulaja also pointed this out, was around how do you make sure that these innovative financing mechanisms enhance progressivity. I would like to, I'll explain a little bit about that, is also how they expand equity. How do you make sure that these innovations are focused or are embedded on the tenet of equity? So I've talked about stability or consistency, I've talked about sustainability, and I've also talked about equity. Now, I want to unpack the concept of equity just a little bit in terms of how sometimes when you're engaging with health economists, how we look at it, right? When you're looking at, let's say, how you enhance progressivity, an innovative financing mechanism, whether it's going to be, introducing a new tax, whether it's going to be results-based financing or any other that I'm going to explore a little bit later, I think the key thing you're looking at is how do you make sure that the contributions towards these mechanisms, in terms of how they are compared to people's ability to pay into this mechanism, is not solely dependent on their income. Because if you look at, there's an index we have called the Kakwani index, and that looks at progressivity. Specifically, it looks at contributions to the mechanism versus in relation to their income or ability to pay into that mechanism. And for people where a Kakwani index is relatively negative, that means it's regressive. That means people who are not able to pay into it or are paying more into it, and it's actually inequitable, because the people who actually can afford to pay into it are not paying into that mechanism, but those who are not able to are kind of being forced, and as a proportion of their total, as a proportion of their income, it's actually quite a lot that you're eating into to be able to afford healthcare services. And that's why there's a very huge aversion to things like out-of-pocket payments, where somebody has to pay at the point of care. And I think those are some of the reflections that are going to be very important when we look at these, or we dive into these health financing innovative mechanisms. Now, one of the exercises I usually like to do is I want to actually ask the audience, the participants, if you could just point put in the chat box. If I was to give you a budget, right? A budget of a certain amount of money, and we'll work with percentages. And I was to tell you that you had to distribute this about, let's say 100% into 5 ministries or 5 sectors, one of them being health. So I'd tell you something like defense, I'd tell you something like health, of course, and I'd tell you agriculture. I'd also tell you industrialization. And then the final one is probably transport, right? So I've talked about defense, I've talked about health, I've talked about industrialization, I think. I've talked about, so across those 5, how would you distribute them, or how much would you allocate to health? If you had 100%, what percentage would you allocate to health? So just put it in the chat box as I continue talking. I'd love to see some of your reflections. So this is just 5 ministries, right? So you have 5 ministries. So if you could tell me how much you would put to health, how much would that be, right? And there's a reason why I'm asking, because, and I love asking people who are in the health sector and people who are outside of the health sector. So I can see someone has put in health, they give 25%. Anyone else? 35% to the health sector, very interesting. Keep going, keep putting 10% of revenue to health. Someone says depends on the demand. So someone was listening to the previous lecture, 27, 35. Some more people, anyone else who wants to point out something, another number, 30. I'm looking for one more. 35 and 30. Someone said 45, right? So I think that's actually the highest we've seen, right? The reason I asked this question is because when you're in, for those of you who have the capacity or who do this directly as part of your engagement, when you're engaging with ministries of finance or financial officers, one of the key challenges they have is that while it's very easy for us as health to point out that there should be more allocation to health, it's often actually very impossible. It's very difficult for them to do that. It's not as simple. Exactly. It's also dependent on the priorities. Thank you, Dr. Ngoko, because there's so many challenges that at a policy level, ministries of finance are actually grappling with. If you are in a country where there's conflict, you'll often want to invest more in your defense. If you are in a situation where food insecurity is a big problem, you want to invest more in agriculture. If you are in a challenge where you're having a lot of challenges when it comes to being able to raise, where there's drought, you want to invest more in industrialization, specifically around water and being able to increase your water resources. So I think these are some of the nuances or the challenges that you must have or must consider, or why innovative financing is something that a lot of people have been really grappling with and thinking about and sitting down and reflecting upon. So we have a lot of, there's a question around what about social welfare and development. So I've only given you 5 ministries, but you can imagine in a situation where we have all the line ministries, where all of them are coming to the door of the Ministry of Finance and expecting a portion of that allocation, the possibility of even being able to sustainably give 15% or 20% or even 30% to the health sector is actually a very huge ask. And one of the challenges you have with the health sector is to effectively measure the outcomes. These are often much longer term, outside of the budget timeline, and often ministries of finance are pegged to those outcomes that you promised to have those reflections. Now, in terms of, after talking about all of these things that these innovative financing models should have, let's go into what some of the examples of these innovative finance models are. So I'm going to give you 5 examples. I'll also give you some reference materials that I'll put in the chat box where you can find more details about these materials. The first one is results-based financing, and I'll go into a little bit more detail about what that means. And then the second one is around catalytic funding. Then the third is around impact investing. The fourth is around socially responsible investing. And the fifth is around new channels of taxation, which we've also just heard of from the examples Dr. Okulaja gave us. So I'll start with results-based financing. And there are very many examples of how you can get results-based financing as an example. But I'll talk about two examples of when we say results-based financing. But basically the underlying principle of results-based financing is where any funding that you're giving is actually based on an agreed set of results that you, or indicators or targets that you want to focus on. So you're paying for a result, right? So that you're driving a focus more on the outputs and the outcomes of a particular intervention, rather than focusing just on the inputs, where you're just buying, whether you're buying a particular technology or you're building a particular set of infrastructure, you're focusing more on the results of what that intervention is supposed to deliver on. So that's what results-based financing means. But then in detail, there are examples of this, and I'll give an example of one, which is debt swaps. And basically debt swaps are where you look at a country's debt profile, and you look at how, if there is an external agency or an external partner who is responsible for looking at that debt, where you kind of do a trade-off between the debt that is here and you swap that out for a portion of it is swapped out or transferred, so that you allow for that now new funding that is now presumed to be available because you are no longer servicing that debt, where you're able to contribute that towards a social intervention. You reallocate that money that you would have ideally been servicing that debt towards, servicing that debt. You reallocate that funding towards something else, which is a social intervention. And in this case, we're talking about health. So that's an example of results-based financing in terms of how do you make sure that it's kind of like using a carrot to entice a government to shift focus towards a particular area. And there's some examples of these, and I'll give you my cautions with each of these examples and why it's important for us to understand those core principles that I talked about. The second example I can give around results-based financing is almost like it's almost like the same thing. It's performance-based financing, where you pay, but this is more specifically to healthcare providers. By this I mean people who work in the healthcare facility or healthcare workers, where you pay directly for an agreed set of targets, agreed set of results, and agreed set of indicators. So you're incentivizing the healthcare worker or the healthcare facility or the healthcare provider by saying that for these set of results, this is actually what we're going to pay for. So you're paying for the performance of the healthcare worker, the healthcare provider, or the healthcare facility. So one of the challenges that have been experienced when you look at results-based financing is that the key thing to understand is that sometimes it creates perverse incentives in terms of how people view the incentive, right? And often, sometimes it actually distorts the approach to a more sustainable financing mechanism for that process. But there are some examples where this has been used, and specifically in primary healthcare. But I think the key caution here would be, remember those tenets I talked about. I talked about the sustainability of certain of these incentives. I talked about the consistency in terms of these incentives. I talked about also the equity in terms of how does this advance equity? How does this advance sustainability? And how does this advance consistent flows of funds? So those are some of the questions I want us to keep having at the back of our minds when we look at some of these innovative financing models, because there are very many, and I'm not even mentioned all of them, and I won't be able to, I wouldn't be able to go into details of them, but I will send you some resources in the chat box that you can review and reflect upon and see if those might fit for what you're looking at, right? Another example that you do have is, I talked about, so those are two examples of results-based financing. One of the examples I also wanted to give is around catalytic funding. Now, one of the things with catalytic funding is that the idea behind catalytic funding is where you're actually able to pool resources and be able to focus on kind of like a one-time investment innovation that will be able to be further in which, like an initial kind of like initial capital that you want to put into a particular investment within the health system. This is in the context of the health system. So there's examples of catalytic funding around like pooled investment approaches. And this is, an example of this is like, we have the Global Fund, we have Gavi, right? Most of the examples that we have of these are more vertical disease programs, where you have being able to bring investors together and have them focus on one particular issue. And they invest they put all their money into a pool, and they consolidate that pool so that it's focusing on one specific area. So one of the challenges that you do have with this is that there's been a lot of successes with these pooled investment approaches. And I'm sure you have examples of them, the Global Fund, and you have Gavi, and you have all these investments that have been made in TB, in malaria, in HIV. And I think the key thing, again, to ask yourselves there is how then do some of these pooled investment approaches then transition into more sustainable approaches for innovative financing, right? And I want us also to look at the larger conversation around resilient health systems. So what exactly, how do these innovative financing mechanisms link back to our conversation around resilient health systems? How do they make sure that we are resistant to any shocks that may destabilize the system? And then the second example around catalytic funding is on public-private co-funding, where I think, again, it was outlined a little bit in the earlier conversation around public-private partnerships. And the design of these are basically on the premise that there will be kind of like a mutual gain for both the public sector and the private sector in terms of the investment that they're being put on that's being put on the table. And then the final example I'll give around catalytic funding is around revolving funds. And this is where you look at revolving funds basically give a focus on where you procure mostly supplies. This is more related to supply chain. And you're able to kind of pool again your resources so that you are able to procure particular supplies at a better cost with of a higher quality and at a relatively lower price. So I think the one thing that we have to have as a caution here again is with these examples I've given you of catalytic funding, how do we make sure that these are not displacing already pre-existing domestic resources that are available? One example that we have to also give is one example that actually has been seen to sometimes destabilize the domestic resources that are available is sometimes we see that in donor funding or in overseas development aid. Where we see because funding has been put into a particular area, then funding is then redirected by the government towards something else, and it actually reduces the overall pocket of funding that's available for healthcare or for that particular intervention. And then in the long run, this actually is counterintuitive towards the things I was talking about, those tenets of sustainability and consistency. So it's basically where you just replace what was there and you actually, you take that funding elsewhere. Now, I've talked about all of these things around results-based financing. I've given you some examples. I've talked about some examples of catalytic funding. I won't talk about new channels of taxation because I think that's something that Dr. Okulaja also pointed out. The only caution I would also give there is around the new channels of taxation, is that sometimes the evidence has shown that these actually end up reducing the overall financing towards the healthcare system. And again, when you talk to ministries of finance, they often see these as, if there's funding that's been directly allocated, then their response is actually to reduce the overall funding that goes towards the healthcare system, because they see that there's actually other taxation that has been directed, channeled towards the healthcare system. And so I've talked about the results-based financing. I've talked about catalytic funding. I've also talked about a little bit, we've had a discussion on new channels of taxation. And then there's also impact investing and socially responsible investing. And I think these are basically pinned on the same principle of focusing more on the impact rather than on the financing, and trying to identify what the key challenges are that can be addressed and the kind of impact that you can have around those challenges. Now, I've talked about these innovations. I've talked about the core principles that you should have at the back of your mind for whatever the innovative financing mechanism that it may be. What are the considerations that do you need to make? Now, having said that, I think one of the things that sometimes we often forget is that there's a lot of questions around things to do with efficiency in the healthcare system. And this is a conversation that actually ministries of finance and ministers of finance are actually very excited to engage in when it comes to speaking to the ministries of health, because efficiency is one of the things that we don't quite talk about as much as we should. And I think my colleague who was previously here for the previous webinar spoke about, because his docket is in strategic purchasing, which is, and there's a whole entity called SPARC, which is Strategic Purchasing Africa Resource Center. And they look at how do we make sure that we are actually purchasing more strategically rather than passively, which is what quite a number of countries are still doing. And I think there's an opportunity there that we can actually leverage to increase the amount of resources that we can actually dedicate towards the health system. And this is an opportunity actually for a very deep and meaningful engagement with ministries of finance. And I think one of the key things that is an opportunity here for us is around how do we make sure that whatever innovation that we do select, how do we make sure that there's a more multi-sectoral approach in our selection of these innovations? And how do we break down the silos? We often see conversations around global health security being separated from conversations around universal health coverage. Yet it is the same resilient health system that is expected to respond to patients who, whether they come with a global health security issue or whether they come with just a general issue like non-communicable disease. So how do we break down the silos, not only within the healthcare system, but how do we also effectively engage with people outside of the healthcare system who would be able to help break down those silos? And I think there's a lot of conversations, and I think there's actually a lot of work done. A good example is in Nigeria, where there's a lot of budget advocacy and budget conversations around how to unpack what budgets really mean, especially when it comes to how you engage with communities at that level and their involvement in actually budget advocacy. And I think that's a very important point, where you actually unpack what the budget means, unpack what is promised, unpack what is delivered, and see what the gap is. Because I think often we say that this is the amount that is allocated to the healthcare system. So it's allocated, but what actually happens when it comes to disbursement? Is that actually what gets to the healthcare system? And you see that, so we talk about the funding gaps that we have in terms of resources, but we don't talk about what actually gets to the healthcare facility to be able to deliver on the service. And these are very important conversations that you can actually breach with ministries of finance and ministries of health, so that you're sitting on a table to actually discuss some of these tangible issues that actually are very actionable and don't require a lot of policy change, don't require a lot of engagement with so many so many stakeholders. So it's a very big opportunity. And I think most of the times it's very important to understand the importance of political will when it comes to these innovative financing mechanisms and the adoption of them and the nuances that come with them, and also being able to effectively make sure that all those tenets that I talked about, those core principles that I talked about, are adopted as part of the whole process. And then a couple of final things as I close is really around, majority of countries have focused, again, as I said, on the insurance model. And it's really important for us to understand that there's no silver bullet. There's no magic bullet when it comes to health financing. I think the key thing here is to make sure we're leveraging on those tenets that I talked about. And we're not trying to replicate what is done in high income countries and replicating them here on the continent, but rather adapting them based off of the context that we have, based off of what the challenges that we're experiencing, based off of what our current economic situation is, but also based off of our projected hopes for the continent and for our countries and our subnational systems are. There's a very big it's a very big move to, I think, have that more transparent conversation around what exactly it means when we say we're having a wave of health financing reforms. Are we exclusively focusing on health insurance because that's the example that we think would work? Or is it because this is something that is tangible? It is based on those principles that we talked about. It is also based off of what Dr. Okulaja said, that we have a predominantly formally employed workforce, that we're able to draw on some of those funding opportunities. So I'll take a pause there, and I'm happy to take any questions. And I do hope that we really remember those. I feel like I've not given you an answer in terms of which innovative financing model you should pick, but instead I wanted to focus on those principles, those core principles that we should consider, and give you an example of what the tenets are. Thank you.
Thank you very much, Dr. Walumbe. Thank you for that brilliant and very informative presentation. That's quite informative. You actually unpack a whole lot of information, and you give a core principle details on what we should expect when it comes to healthcare financing models. And I think that will be helpful. You actually expanded on what Dr. Okulaja have said. You spoke about, you really emphasize on these principles that should guide whichever. We understand that there is a deficit or there is challenge of healthcare financing, especially in Africa or low-income countries, but you guide us with the core tenets and principles that should guide our healthcare financing models we want to adopt whichever way. We should spoke about stability of the funds and sustainability. You equally emphasize on the equity, of which are the core principles we mentioned about. Then you went further to talk about the financing models, the different kind of 5 different kinds of healthcare fund models that we can adopt, but which should be of helpful to us in Africa. So kindly be on standby for questions. We are going to look through the question and answer, and I'll be allocating questions to either you or Dr. Okulaja as specified by the questioner, or we can apportion it from the Secretariat. So the first question from Naman Ravi, he asked how, I think the question is to Dr. Walumbe. How will a government like Nigeria increase traditional spending when greater than 80% of tax revenue is spent on domestic debt servicing?
So thank you so much for that question, Ravi. I think one of the things that mentioned was that I gave an example of the debt swaps in results-based or a challenge that you're facing. I would give the example of that results-based thing would be useful. I'll give you the document in terms of what you could consider as an answer to you. But I think one of the key things that we also need to focus on is how we are consolidating our finances that are already being allocated towards healthcare. That's the first thing, because that actually increases efficiency. And for a country as large as Nigeria, I think one of the key things that there are some examples in terms of how there's a lot of fragmentation in the approach when it comes to fragmentation of the pooling. And I think fragmenting of the pools actually reduces the amount of money that you can allocate towards healthcare. So I would give that as an example of how do you deal with the debt servicing. An example is the debt swaps, but again, this is also for it's very useful for countries where you already have in-house financing that is available, where if you swap that debt, you can actually leverage the finances you do have in-house for something else. So and I think Nigeria is an example of that. Then the second answer I've given is on the defragmentation, so that you increase efficiency and you hopefully have increased funding toward them that you can allocate to healthcare. Thanks.
Yeah, thank you, Rispah. Yeah, the next question, I have a question here for Dr. Okulaja, I guess. Yeah, you mentioned fragmented pools. Can you throw more light on these with examples? Olamide.
Yes, hi. Okay, so when we talk about fragmented pools, basically what we mean is that we have different silos of pool funding for different things. So for example, you have, first of all, if you look at the health insurance space, you have the private health insurance, and then you have the social health insurance. Under the private health insurance, you have different health insurance organizations that are managing different sets of people that are paying into their own pool. So that in itself is fragmented. Under the social health insurance scheme, you have your state health insurance scheme, you have your national health insurance authority schemes. And so what is happening is that you have different pools of funding, which if put together would have been a lot more stronger in a synergistic approach. Beyond health insurance, you now have different donor agencies and developmental partners that are funding different things. So you have a situation where, for example, the Global Fund is interested in malaria, HIV, and TB. You would have a situation where the Bill and Melinda Gates Foundation is interested in propagation of family planning initiatives. You have situations where HP Plus is interested in something else, and all these are coming with different fundings. And what that does is that it sort of promotes a dispersed health finance, a health planning system where different people are funding different things based on interest or based on their own niches. And what happens is that we are now unable to harness the possibility or the strength of these individual risk pools as against if they were all put together into one single pool and used to purchase services in a holistic manner, in a more generalistic manner that covers the entire healthcare system. I hope that this sort of answers the question. Thank you.
Thank you, Dr. Olamide, for that answer. I think that will answer, that satisfy the participant that has that question. Yeah, our next question, I think, is for you, Dr. Olamide, as well. Yeah, the question goes to how will universal health coverage ensure that there is equality healthcare service to the hard-to-reach areas?
You see, this is one of the benefits of a sustainable and effective health financing mechanism, because one of the reasons why you have a propagation of people into the urban areas versus the rural areas is because a lot of people are following the money. Unfortunately, if we are relying on out-of-pocket payments in our health financing mechanisms, the possibility that people in rural areas are able to actually pay for those services is very limited. However, if we have a health financing mechanism that guarantees that the desired quantity of services will be met by a financing mechanisms, you would realize that people would actually stay in the rural areas and cater to these people that require services. Essentially, if the services they're able to provide would be financed, then you would have a situation where you begin to have a redistribution of healthcare services across board. And so what's important is to strengthen the ability of the healthcare system to be able to finance effectively the desired quantity of services that are required versus just looking at the silo approach and in a system where it is essentially reliant on out of pocket. So I hope that answers the question.
Yes, I think so. And Dr. Walumbe, Rispah, will you want to add few words to the question?
Yeah, sure. So I think again, it's very nice to come after Dr. Okulaja because he tends to answer the question very comprehensively. But around the conversation on this is around UHC UHC, right? And I think one of the things that UHC affords us is we are able to focus on kind of like a unified approach for how we attack the challenge that is delivering healthcare within the health system. So I'm definitely in agreement with what Dr. Okulaja said. And I think one of the principles or the tenets that are reflected in UHC is around equity. And I think that's something that's really important for us to ensure that we're extending equity in our approaches towards universal health coverage, because each country is actually responsible for designing their UHC approach. And in the there's a report that was done by the AHIC Commission on the state of UHC in Africa. And in this report, what it actually identified was the fact that while services were generally increasing in terms of service availability across the region, the key challenge we actually had, or the worst performer in the 3 tenets of UHC, was actually around quality. So there's still quite a bit of work that needs to be done on the quality of service that we're delivering. And I think this then outlines the question around quality also has the answers the question around outcomes and the impact that we're actually having when it comes to the healthcare system. So I think UHC gives us an ability, kind of like a foundation to engage around quality, because quality is a tenet of universal health coverage. So I think if we have a really clear engagement and focus around that, that's one of the gaps that we have when it comes to addressing quality. And I hope that that's something that a lot of the stakeholders here will be able to engage in. But as I said, I'll post the report there for you to reflect on. And as you can see, service delivery has increased, but the tenet of quality is actually the worst performer when you look at financial protection, equity, and service delivery. Quality is the worst. Thanks.
Thank you very much, Rispah. The next question, I think, I don't think we have any question. Yeah, I don't think our question is almost gone. Yeah, our participants, if you cannot put up your question here or you're busy, first we will still share some of the clips of this presentation, so our email to all our participants. We will give them their certificate along with the presentation, so you can still put up your question. Then Dr. Rispah promised to send some of the clips and some links to us, so we will share it with you once we get that to all our participants' email. So, all right, we've spent close to 2 hours on this. So as the webinar gradually draws to closing, I want to express our gratitude to our speakers, Dr. Olamide Okulaja and Dr. Walumbe, for taking time out from their very busy, tight schedule to share some of their experience and knowledge with us today. We look forward to seeing you next time. Also, our participants across the globe for keeping faith with us every month on this educative and informative platform. We really appreciate you, and we look forward for more information, for more catch-ups on our activities and events. We usually follow up this webinar series with a policy brief. You can get that on our day. Our newsletter is equally available on our website. And finally, our annual biosecurity conference is coming up in November, 1st to 3rd of November. The registration is ongoing. You can get, on our chat box, the link has been shared on our chat box on how to register for registration. The registration is still ongoing. It's fast going. Is coming up in 1st to 3rd of November. This is one of the biggest biosecurity conference across the globe. It's undoubtedly the biggest on the continent. So you can join us, you can participate on that. So on that note, I want to draw the curtain of today's webinar to a close. Kindly join us again next month for another exciting webinar series in the month of June. So I say bye-bye from here.
Thank you very much. Bye-bye.
Bye.
Thank you. Thank you very much.
Yeah.